Welcome everyone to our first special guest event in the Navoni community. We have Kathryn Gilliam. Kathryn has been on the front lines of early detection of oral cancer throughout her 20-year career as a top-producing clinical dental hygienist. Kathryn teaches teams and audiences around the country an elegant and thorough head and neck cancer exam that both relaxes patients and raises their awareness of the importance of regular cancer screening. She is an active volunteer for the Oral Cancer Foundation and supports organizations such as the Oral Cancer Cause, Atlanta Smiles, and 6-Step Screening. Kathryn has developed impactful continuing education courses to both small and large groups across the country. She is a graduate of the Lioness Principal Advanced Transformational Training Program. She has published continuing educational courses for Indici.com and drbicuspid.com. And Kathryn's articles have been featured in the Journal of the Academy of General Dentistry, AGD Impact, RDH Magazine, Dentistry Today, Dental Economics, Modern Hygienist, and Hygiene Mastery magazine. Additionally, Kathryn is a member of the American Academy of Oral Systemic Health and is a member of the board of the Houston component of Oral Cancer Foundation. She is also a member of the Speaking and Consulting Network and Directory of Dental Speakers. And Kathryn is a very good friend of mine and an amazing woman. So I am super excited to have her join us in our Dentrix online community as a special guest. And so what we would, so super excited to have you, Kathryn. So Kathryn's going to be talking on a topic that we haven't had in our community before, and it kind of relates to what our webinar was last month, which was all about clinical note templates. And so Kathryn is going to be talking a lot about proper documentation. She's going to talk a lot about screening. And so some of the things that Kathryn is going to talk about today directly relates to what we talked about last month in our Dentrix user meeting, all about clinical note templates and making sure that you have proper documentation when documenting your patient's hygiene visits and comprehensive exam visits. So throughout the presentation, if you have any questions for Kathryn, I'll be monitoring the questions, and if it's a question that relates to something that Kathryn just talked about, please put your question in the Q&A box so I can forward that question to her, and she can, and I'll ask the question live so the entire audience can hear. So without further ado, I'm going to let Kathryn take over. I'm going to be running Kathryn's slides for her, but Kathryn is going to take over the presentation and just fill you with a lot of really good information today.
Thank you, Dana. I'm really excited to be here. I appreciate you inviting me. I'm happy to be here with your audience because I think this is a tremendously important topic. And I'll tell you, as I go in offices to coach and train dental teams, I find that their documentation of the oral cancer exams is really inadequate, probably 99% of the time. And that's concerning. Most of them will write the initials WNL after they write their exam note. And WNL is supposed to mean within normal limits, but it's considered to be the same as we never looked. It's not enough to write WNL, and I see it far too often.
I see that a lot too. Another thing I see a lot of times with clinical documentation is on the health history updates where they will write no changes, you know, and there's just very minimal documentation about oral cancer screening and the health history update. So I think this is such an important topic.
It is, and maybe we'll come back sometime and talk about those health history updates, because the more we know about the link between oral health and systemic health, the more critical we realize those health history updates really are.
Great. Okay. Are you ready to get started with your slides?
I'm ready.
All right.
Okay, so we'll start with a few statistics before we get into documentation. And just note that oral and pharyngeal cancers are what we're talking about when we refer to head and neck cancer. Brain cancers are in their own category and not included in our head and neck cancer exam, obviously. Okay? And in the U.S., approximately 48,330 people will be diagnosed with a head and neck cancer this year. There are approximately 9,570 deaths expected from head and neck cancer this year. And of those 48,330 newly diagnosed people, only 57% will be alive in 5 years.
Wow, those are staggering statistics.
It's really scary. Okay, and we know that the death rate is high because it's typically diagnosed in late stage. And what I say is the great shame of our profession is that head and neck cancers are routinely discovered not in the dental office, but by other medical professionals.
Yeah, and I always stress to my doctors that they are the oral health physicians, that they really need to take on this role. Wouldn't you agree?
Absolutely. I think it's critical, and it's our responsibility that these patients be discovered in our chairs.
Absolutely.
The 5-year survival rate has improved from 52% to 57%, but it's because the HPV-related cancers are easier to treat. They're more susceptible to the treatment that we do. And that's good news for those people diagnosed with HPV-related cancers. But the statistic isn't improved because we're doing a better job with early detection. And that concerns me.
Mm-hmm.
Now, the factors contributing to poor prognosis are varied, and typically a patient will not notice pain or symptoms in the early stages. And also, clinicians may not even do a comprehensive head and neck cancer screening. I see that far too often when I go in office with dental teams, so it's non-negotiable. If I'm going to train or coach a team, they have to commit to doing a comprehensive head and neck screening for every patient at every appointment.
I agree with you. I see this a lot in my practices where they are not even documenting oral cancer screening because, you know, one thing that I help my teams with is creating clinical note templates in their Dentrix software. And whenever I come to the question of oral cancer screening, what kind of typical answers would you have, you know, negative or positive, refer, and they're like, we don't document it. And I'm so surprised how many offices don't do oral cancer screenings. What do you think? Do you think it's like fear of the diagnosis? What do you think is causing offices not to do the screening?
What I see is that, and what I hear from those clients is that they don't know what to look for, so they don't look. And that's absolutely the wrong thing because as dental hygienists, we're not responsible for the diagnosis. Our responsibility is to find and document and make the dentist aware of any abnormality that we see in the mouth. We don't have to know that it's cancer.
Right. Yeah, you just have to be looking for it and then know what's your protocol in your practice. Are you going to do the biopsy or are you going to refer? I just think it's our responsibility as oral health physicians to take on this role.
Absolutely. It
yeah.
is really. And I do a lot of training on oral cancer. I show a lot of photos. I help them know what to look for and reassure them. And I want to reassure all of you out there today, it's not your responsibility to diagnose. You
right.
don't know that it's cancer. Find something abnormal, make your dentist aware, and document that in the patient's chart.
Absolutely.
And go from there, whether you need a follow-up with a specialist.
Yeah, absolutely. It's so important.
Another thing that contributes to poor prognosis is that a clinician may do an exam but not notice a lesion because they're not always easy to see. Or they may notice a lesion but not follow through. They may not show the dentist or tell the dentist. They may not recommend a biopsy because they don't know what they're seeing. And that's very, very common.
What do you think about, do you feel like hygienists may run out of time? Do you think that maybe our team, like our scheduling coordinators or the doctors, aren't allowing for time during the appointment to get it all done?
That definitely happens in a lot of cases. And one of the things that I do when I work with teams is make sure that the hygienists have enough time to do a comprehensive head and neck cancer screening, as well as all of the other screenings and treatment that they need to do in that time period. So for me, less than an hour for a routine periodontal maintenance or prophylaxis appointment is absolutely unacceptable. And you need an hour and a half to 2 hours for a new patient, but that's a different topic.
It is, definitely. I agree with you.
But I will say that very often hygienists will tell me they don't have time, and I've timed it. So I know in my own practice it takes me approximately 3 minutes to do a comprehensive head and neck cancer screening. That doesn't include all of the documentation, but the examination itself takes 3 minutes. So there's no excuse for me, for anyone, not doing it for every patient at every appointment. And if you run out of time, I would rather you reschedule the cleaning than any of the data gathering or documentation that you need to do.
I was just about to bring that up. I would say that we could probably cut, 3 minutes off of the prophy, or 3 minutes off of the hand scaling, because you could always reschedule the patient for another 20 minutes or pick that back up at their next 6 months. But to miss that oral cancer screening, I think, is much more valuable than 3 minutes of the prophy.
Absolutely. It is life and death.
Yeah.
So there's no excuse for not doing this examination. If you aren't comfortable, if you don't know what you're looking for, it's perfectly understandable, but there are a lot of ways to get that information. So there are many, many courses throughout the country, even interactive courses that I do where you'll do a cancer screening right there in the meeting, that you can educate yourself. And there's certainly CE courses online. I have courses. There's lots and lots of photos on just Google if you see what various types of cancers look like, and educate yourself and do it. The more exams you do, the more comfortable you'll get, and you'll begin to recognize, as I'm sure you probably already recognize, different features of the mouth and different lesions. And there are so many lesions that are not cancerous that we see all the time. You'll be able to recognize that and say, well, that's Fordyce granules, that's not Candida, or that's not squamous cell carcinoma. So the more you do it, the more comfortable you'll become.
Yeah, and I know you're going to show us a lot of those screening things today. So, yeah, absolutely.
Okay, we can move on if you like.
All right, good.
And this slide is so important to me. I think we need to make sure that we're broadening our idea of who we screen for cancer. Young people, especially with multiple sex partners, are extremely at risk for HPV-related head and neck cancers. And I will tell you that a lot of people don't want to imagine that people in the 11 to 17-year-old age group are having sex, but it's happening. We're talking about it, and we're screening them. And in fact, I screen toddlers. So any person that sits in my chair, they could be 18 months old, they get a head and neck cancer screening. And it tickles. It's a nice bonding moment for us. And it gives me a good look at what's going on in their mouth and their throat as much as I can.
And the earlier you detect it, the higher rate of survival.
Absolutely. And I will tell you that the youngest child that I ever heard of that had cancer was, or oral cancer, was a 6-year-old girl with a tumor in her palate. So after learning that, I made sure I never excluded anyone from this exam. I don't usually start using fluorescence until about 11 or 12 years old. And I always recommend to the parents to get the HPV vaccine. It's been controversial in Texas, maybe in other places, but I really believe in it, and I recommend it to all the parents.
It's an important topic, for sure.
It is. We know that the highest risk category is still men over 65 who use tobacco and alcohol. Their risk is twice that of women, but those people with HPV-related cancers are almost overtaking that group for highest risk of oral cancer. It's growing at the fastest rate.
Wow.
Smokeless tobacco users, including e-cigarettes, are another fast-growing category. Unfortunately, our patients who use e-cigarettes are typically younger, and they believe they're safer. But we know that they're not safe, and we do see cancers occurring in those users.
So I do have a question that has come up because it is related to this specific slide. We have a few of our members who are have practices in states where marijuana is legal, like Washington and Colorado. And the question is, have you done any statistics on the risk factors with marijuana, smoking, or anything like that?
I don't have the statistics at my fingertips, although I read them not too long ago. We do know that using marijuana does contribute to oral cancer, and there was a time that it was considered to be safe. But we know that it's not safe, just like cigarettes and tobacco, are not safe. So unfortunately, I don't have the statistics. I can get them for you.
Okay.
We know that it's not a safe practice.
Okay, great. Thank you.
Okay. The typical signs of head and neck cancer, you or the patient will notice a sore or irritated spot, a lump or a thick patch in the mouth, the lip, or the throat. In early stages, patients tend to dismiss those things, especially in the throat. Typically, the patients that I've seen with a lump in the throat think it's just a swollen lymph gland and they're coming down with something and it'll go away. People don't want to imagine that it's cancer. So be sure that if you feel a lump, you talk to them about it, find out how long it's been there or a sore spot, and continue to research that. It's often, sadly, something very dangerous. Of course, white or red patches in the mouth. A feeling that something is caught in the throat is also a common sign. And difficulty chewing, swallowing, moving the jaw or tongue. There's often some numbness in the tongue or a certain part of the mouth that's unusual. And patients also can complain about their dentures not fitting well. So when someone comes in with a denture or a partial that's not fitting well, make sure that you look beyond adjusting that denture or partial and really check the ridge, check the mouth, and make sure that there's not a swelling that's causing that discomfort, because it could be a cancerous lesion. Also, sometimes people have pain in the ear. They don't have hearing loss, but they will have pain in their ear. Sometimes they think they have some type of a sinus infection, but we need to follow through and make sure that it's not a cancer.
Good tips. Thank you.
Okay, now this is the absolute must-have notation. It says that you performed the standard exam and that you added a fluorescence device if you did, and you should specify which one you used, that the patient wore the safety glasses.
Okay.
It is critical to note that you didn't find an abnormality or that you did find an abnormality, And if you found an abnormality, could you identify it? Was it a cheek bite, a traumatic lesion, a pizza burn, whatever you see? If you can identify it, note that. Then if you can't identify it, note that you have a lesion, you don't know what it is, and we'll go on to describe it. That way you'll know whether you need to follow up with a specialist for a biopsy.
Yeah, this is really good information, especially for our members, our Dentrix users, because it relates directly to the user meeting we had last month, which was called Efficient Clinical Note Templates. And so what we learned last month in our user meeting was how to make the documentation more efficient, make it faster for our clinicians, because I think one of the things our clinicians struggle with the most is doing the documentation. And so this is a great great information for when you go to build your clinical note template, because you can create these check boxes, just like Kathryn noted here. What kind of screening did you perform? Oral ID, bell scope, maybe it was just a visual exam, but it looks like here you have to document exactly what kind of screening you did. So that can be part of your clinical note template, your checkbox, and then what kind of abnormality was there and if it was identified. So this is a way that you can create checkboxes within your clinical note templates in Dentrix to make the documentation not only specific for that patient, but also make it faster for your hygienists and your clinical team so that they can get that documentation in the clinical note as quickly as possible.
That's exactly right. And make sure that you realize that if you use a fluorescence device like an oral ID or a Velscope or any other device, that's only part of the exam. It always follows the intraoral and extraoral exam, the visual and tactile exam. That has to be done first, and then you follow up with your fluorescence device. To just use the device is not a complete exam.
Okay, good to know. So that would also need to be created in your clinical note template in your software. So that's important to know for sure. Thank you.
Yes, that's why that initial chart entry looks long, but if you have it there already typed in, and that's exactly what your hygienists perform, then it's easy for them to go through and make the other notations.
Yeah, absolutely. So I think that's one of the reasons, we were talking about earlier about how we feel like the hygienists sometimes feel like they run out of time, where if we can make these clinical note entries more efficient for our hygienists, they're more likely to do the screening.
Yes, it will definitely help.
Yeah, good.
And that way the hygienist isn't taking time to write that initial chart entry over and over for each patient all day long, which does take a lot of time. She can just fill in the blank, so to speak, or check a box about what's particularly visible or noted on that particular patient.
Exactly. So for all the Dentrix users in the audience, last month we did the Efficient Clinical Note Template webinar, Dentrix user meeting last month. So please rewatch that and take Kathryn's documentation tips here and add them into your clinical note template. I'm really asking you to do that within the next week or so.
Okay.
Great. Oh, now we get to see the pretty pictures.
So now, once you realize that you have an unidentified lesion, that's when we go into all of these lesion descriptors. And we need to address all of the following categories. We're going to note the location, the color, the size, the margins or borders, the number, and the description.
So this is, so I really like this, Kathryn, because this really gives our users, our members, some really great template information. So if you do find something like an unidentified lesion, you can actually create a template just called unidentified lesion and create these questions in your template. And then what would be the answers that you would have to choose from? Like location, you might have 5 or 6 checkboxes. The color, you might have, you know, 6 or 7 checkboxes for different colors. So this is really, really good to take a screenshot of this, because this is a template that you could build in Dentrix called Unidentified Lesion. All 7 of these topic headers would be prompts in your template. And then what would be the checkboxes within those prompts, okay?
Exactly. This is a great outline for that.
Yeah, perfect. Oh, this is really good information.
And if you're interested, what you're looking at there is called erosive lichen planus.
Okay.
I don't know how many pathology people we have standing by, but I love my pathology.
I know. But this is really good for the clinicians to see the pathology, but also for our administrators, how they can see how to build the templates and maybe help the clinicians build the templates, because a lot of times it's the administrators that kind of know how to use the software, but it's the clinicians that need to supply the answers, what the answers would be.
Right. I think clinicians and administrators need to work together to build the template so that the pressure's not on the administrator to know everything that
yes.
the clinician needs. You can't.
Exactly.
So working together, you'll get the ideal templates for your practice, and then everything flows much more smoothly. And this slide is a continuation of that outline for your template, because also we'll need to note if the patient has any pain or numbness, if there's any restriction of movement, if there's any swelling, if they have sensations. For example, they're feeling something in the throat and they can't swallow and it's still there, or how that lesion reacts to your pressure. So these are more categories that the clinician will need to fill in from the template.
Okay, good.
Oh, sorry, and those lesions are squamous cell carcinoma.
Okay.
Those are serious.
Yeah, looks serious.
So on this slide, you'll see a continuation of our template. You'll need to note if there was any reaction to the fluorescence, if you took an intraoral photograph, and if you took a photo with fluorescence. And I recommend photos for every lesion that you cannot identify. It's extremely helpful to have that in the chart. It's extremely helpful for someone seeing that patient at a follow-up visit, if it's a different clinician, or for the specialist to be able to see what it is that you're concerned about. You also need to document if you performed a cytology exam and that your patient agreed to that, and also the results of that exam. You'll note whether the doctor asked you to refer to a specialist or to bring that patient back for a reevaluation.
All right, good. Yep, so everybody that's online today, this is just continuation of the same template that you would be building within your Dentrix software in the clinical note template section. So this is so important.
And if you get this template built, then everything after that is much more smooth. The clinicians can answer the questions, check the boxes, fill in the blanks, and that way your patients have very thorough records.
Absolutely.
So you can see documenting the findings from the head and neck screening must be very, very thorough, and we've gone through the outline of the template. And now what we'll do is we'll talk about the details. Okay, so you'll notice on that template, one of the first things we need to do is describe the location of the lesion, and you'll describe whether it's in the buccal mucosa, in the palate, in the gingiva. You'll talk about whether it's on the mesial or distal or at the midline, Is it anterior or posterior? Is it generalized or localized? Unilateral, bilateral? And with the tongue, make sure you describe whether it's on the lateral border, the ventral surface, which is the underside, or the dorsal surface, which is the top of the tongue. So you would say this lesion is located in the anterior right lateral border of the tongue.
Okay, yeah, this is great. So going back to building your clinical note template in Dentrix, what you would want is the prompt would be called location, and then all these bullet points right here would be your check boxes. So you would be able to actually check box what is appropriate for this patient. So what this does is saves you a ton of time when you're doing your clinical documentation.
Exactly. Okay, now an important side note as we start to talk about the color of the lesions, if there are any clinicians on with us today, when I was in dental school, leukoplakia was used to mean a precancerous or cancerous lesion caused by smokeless tobacco. That is no longer the way we use the term leukoplakia. It is now only used for a white lesion, and the lesion that we're looking at in the buccal mucosa here is called smokeless tobacco keratosis. That used to be called leukoplakia. Now it's smokeless tobacco keratosis.
Okay, awesome. So this is just another prompt for your clinical note template in Dentrix. The color would be the prompt, and then you would have these different check boxes in order to check what's appropriate for this patient.
That's right.
Good. Oh, more color.
Okay, so these are red lesions. That's erythroplakia, and a mixed red and white lesion called erythroleukoplakia, or described. And these are both cancerous lesions. Okay. You can also have multiple different colors. Sometimes the grayish lesions are pseudomembranous, and we also have black lesions, yellow, brown, blue, purple, pink. This is candidiasis, and most people would probably describe this as an erythroleukoplakia, a mixed lesion. Sometimes it does look grayish in the mouth, and it's called pseudomembranous. But having these different colors available that you could just check would make it very efficient for the hygienist or the clinician.
Absolutely.
Okay, and we measure any abnormal lesion that we see in the mouth. We make sure that we measure it because that can be tracked, whether it's growing or not. So we simply use our periodontal probe. And we also need to note the number of lesions. So typically an abscess ulcer in the bottom left picture, typically that shows up as a single lesion. But in the upper left picture, you can see it can also be a cluster of lesions together. Very, very painful.
Absolutely.
The lower right is a herpetic lesion, and a close-up of it is in the upper right photo. It's typically seen in clusters or coalescing lesions.
Yeah, so for our for the Dentrix members, the Dentrix users, the size and number would be the name of the prompt, and then your check boxes would be, you know, maybe some common sizes or the number that could be a checkbox as well. So just the documentation and making it more efficient for your hygienist this is what the information we're giving you is so important.
Okay, and talking about margins or borders, we use all of these descriptions, and it's really quite important to the differential diagnosis how you describe the edges of the lesion. So whether it's regular or irregular, rolled, raised, flat, depressed, there are other, we could say indurated, thickened margins. All of those things are important to note. The photo on top here is an early squamous cell carcinoma. It's on the dorsal surface of the tongue, and I would say that that is a white irregular border. And the lower picture is also an early squamous cell carcinoma. I would say that that is a red indurated lesion with a white raised border.
Great. And so I know I keep stressing this, but since we've been talking about documentation and creating a clinical note template that is efficient for the hygienist, the margins and borders would be the prompt name inside Dentrix, and then all 7 of those bullet points would be your check boxes that you could check that would make it customized to that patient.
Perfect.
Yeah.
So when you document their sensations, be sure to ask the patient if they've noticed a sore or a spot in their mouth. I typically don't ask if they've noticed a lesion because that's just scary. But then you'll want to document, do they feel pain? Do they feel numbness? Do they feel anything in the throat? And it's important to know that if they don't feel pain, that doesn't mean that it's benign. Painless is not benign because typically early lesions are painless, early cancerous lesions are painless. So you need to make sure you know if there's pain or not.
Awesome.
So you'll ask your patient if they have noticed any difficulty chewing or swallowing, moving their jaw or their tongue. And as we talked about earlier, dentures or partials may begin to fit poorly or become uncomfortable. So in your haste to adjust a denture, make sure that you're not overlooking a swelling that is potentially life-threatening, like this one in the picture.
Yeah, great. So again, inside your Dentrix software, when you're creating this clinical note template, the movement and swelling would be the name of the prompt, and then these 3 bullet points would be check boxes that would be customized to this particular patient that you're examining.
That makes it so much easier.
It does.
You're also going to check their lesion's reaction. So that's reaction to pressure. If it blanches when you press on it, if it's non-blanching, if it's painful when you press or painless. And you'll note the reaction or the response to the fluorescence exam. So does it glow or fluoresce, or is it dark? And you'll know that if it blanches, that's normal. If it doesn't blanch, that's something to be suspicious of. If it glows, it's normal, and if it's dark or non-glowing, that's suspicious. So you'll note all of those reactions.
Great.
You want to be sure that you have a place where you can document whether you took an intraoral photograph, and of course you'll upload those photographs to the patient's chart. And note also, Dana, if you do one more click, you'll see a photo with fluorescence.
There we go.
Thank you. So you'll make a note, did you take a photo with your fluorescence device, and upload that as well. These are photos of the same spot in the same mouth, and you can see that the normal tissues will glow that light green, and right in the center you see that dark spot. That's where the cancer is. That's the abnormality. And I will say that not all areas that do not fluoresce are cancer. So there are some non-fluorescing areas or dark areas that we see that even though we don't know what they are, it doesn't mean they're cancer. Sometimes it's a pre-malignant lesion, a dysplasia, but that's something that we only know following a biopsy. If you go back to that last slide.
Okay.
We do need to note, I got a little off track there, sorry.
Sorry.
You need to note if you perform a cytology exam, if the patient agreed to that exam, make sure you note that you did get permission, and then note your cytology results.
All right, good to know.
Okay. You'll note also, and have this in your template, whether your dentist recommended that you reevaluate the patient and at what time interval, or if the dentist recommended an immediate referral. You'll note to whom that patient was referred. I think it's also very important to note whether you gave that patient that specialist business card or whether that appointment was made for the patient in your office. And I think it's important also to note your attempts to follow up with the patient to make sure they had the biopsy, went to see the specialist. And you will get documentation from the specialist about when they saw that patient and if they chose to do a biopsy and what those results were. So all of that needs to be uploaded into the patient's chart.
So we've had a question about coding, and I don't know if you're going to get into that at all. I didn't look at all of your slides, but is there a code that you know of for a reeval? What do you think would be the proper code for that, or would an office just make up an internal code?
I believe you have to make an internal code.
Okay.
I can't say I'm a specialist about coding, but I think it's an internal code for that.
Okay, good to know.
And it's important also to know that these signs are highly predictive of malignancy. So if you see a lesion that is firm, hard, fixed, or non-movable, fissured, erosive, or a deep erythroplakia like this one, a deep red, if it's a non-healing painless ulcer or an ulcer with a rolled, thickened border, those are all lesions that should be red flags to you and should absolutely be sent for a biopsy without delay.
Good to know.
There are other signs or symptoms that you could be aware of. Make sure if your patient has a persistent sore throat, if they have a foul mouth odor that's not explained by poor hygiene, if they have persistent nasal congestion, frequent nosebleeds, if they have difficulty breathing or double vision, that's an unusual one, but it has happened. If they have numbness or weakness anywhere in the head or neck region, ear or jaw pain, if they have blood in their saliva or in their phlegm, if their teeth are becoming loose for an inexplicable reason, unexplained weight loss and fatigue, all of those are signs that you need to follow up in, and that can send us back also to that health history update.
Absolutely. I was just gonna bring that up. It's about our clinicians, our hygienists, and even our assistants reviewing that health history update much more thoroughly than we've ever had to before in the past. It's one thing that I talk about a lot when I teach my medical billing course. And it's so important that we start looking at that health history update in a way that we've never had to before.
And we even need to look at our health histories and make sure that they're as thorough as they should be.
Absolutely.
I see that sometimes in offices they're very rudimentary, and we need to know much more and be asking much more detailed questions than we have in the past.
Exactly.
So when you're looking at your documentation, make sure that it's comprehensive so that some other professional who's following up to see that lesion will know what you're talking about and understand your concern. Can it facilitate a differential diagnosis? And will it communicate the area of concern to the specialist? So if you follow this template that we've laid out for you today, it's extremely detailed, and I think that it would answer those questions affirmatively.
I think that this was perfect for our Dentrix users, because last month we just had a webinar at the user meeting about efficient clinical note templates. And so the information you gave us today was perfect for building that oral cancer screening template for making sure that our clinicians are documenting everything clearly and comprehensively and customizing it for the patient. Because, I mean, if you had to handwrite out all those details, I can see where the clinician would say, I just don't have time to do that. But if you build it into a template like we talked about today, it just makes it so much more efficient. And now you're giving your clinicians more time to finish their complete exam.
I think that's right, and I think that that is one way that our administrators can help save lives. I truly do. If they will build these templates for their clinicians and enable the clinicians to do a thorough job and not feel bogged down and not feel that they can't do it and they don't have time, I think more patients' lives will be saved. We'll be finding these lesions earlier, we'll be sending for biopsies, and we'll save people's lives.
I agree. And another thing about the HPV exam and documenting that is we are physicians, and we can't be embarrassed. We can't be afraid to talk about these controversial type of topics with our patients.
That's right. I talk about everything with my patients, and if they're underage, if they're minors, I talk to the parents and let them know we will be talking about this at this appointment. The parents are welcome to be with me in the room or not as they choose. But like you said, we are oral medicine specialists. We're physicians of the mouth. We are healthcare providers, and we can't ignore an uncomfortable topic. We can't be embarrassed. We can't be hesitant or let our own personal values and beliefs color what we see and what we say. We have to give our patients life-saving information. That's our responsibility.
Absolutely. So, Kathryn, we have your contact info up on the screen right now so that our members can reach out to you if they have questions. Maybe how do you work with practices? Do you do in-office coaching? Do you do online courses? How can we find more information about what your courses are? Is the periolinks.com the best way to get a hold of your information?
Yes, they can look at periolinks.com to see what I do. They can contact me, email me for more information. What I do is I do workshops and lectures around the country. I also go in office and I do trainings for individual offices on oral cancer, early detection, and also how to take care of patients undergoing therapy for cancer, all of the oral ramifications that we need to be aware of and help our patients deal with. I also train people on the oral systemic connection and how to make those links and how to use that information clinically to improve the health of our patients through comprehensive periodontal treatment, targeted nutrition, and I also speak to groups. So I speak a lot to dental hygiene associations and at dental meetings. So you can find me around the country and next month in Cancun.
Oh, nice. Nice. That'll be great. Well, we appreciate all the great information you gave us today. I think that this was just perfect for our members to help them with their Dentrix, their clinical note templates. And we really appreciate you sharing your time with us today.
Thank you. I've enjoyed being here, and I really appreciate your attention to this topic because it means so much to me. And I know by building these templates, the hygienists, the clinicians will be so much better able to find these lesions and save more lives.
Awesome. So just so everybody knows, we did record the meeting today, so it will be uploaded into the Novoni events page. And we will also send you out the link, the private link to rewatch it so you can share it with your team. Okay, I hope everybody has a great weekend, and thank you again, Kathryn.
Thank you, Dana. Thanks, everyone.